Yes, please.
Namaste to everyone. My name is Chandrasekhar Koneru. I am a practicing internist in Huntsville, Alabama. I am a heartfulness practitioner and I also a member of the AAPI. And I've been associated with Medicover Hospital for the last few months. And welcome to all the panelists, all the participants, and it's good to see everyone. You know, the today's topic is very commonly used our one of our therapies, oxygen therapy, and it's also an interesting topic. And during our conversations with our physicians in India and here, there is a lot of awareness need to be. We all need to be a little bit more aware of the oxygen therapy. As not only as physicians, but also as the family members, the patients, caregivers, and people caring for the people at home, in the hospitals, and in the ICU. So Dr. Srikanth Davuluri is a practicing pulmonologist and intensivist. He has extensive experience in dealing with the COVID patients, both in his practice as in the outpatients and also in the ICU. So Dr. Srikanth has been associated with us for the last 1 year. And we started this telemedicine program for our Indian patients about a year ago. He was participating from the beginning and he was educating the doctors and taking some telemedicine consultations for us. So thank you, Dr. Srikanth, for this. And as I mentioned, he practices in near Chicago, Illinois, in USA. And he's very well recognized physician in that area. And also we have a number of panelists, Dr. Hemant, Dr. Raghunath, Dr. Mohan Maharaj, and Dr. Mithilesh, along with Dr. Manish. Manish
will be joining us.
Right.
Manish, yeah.
So so just quickly that Dr. Srikanth is going to help us to understand the indications of oxygen therapy. What are the devices that we can use, and what are the modalities that we can use in ICU in intubated patients, and what is prone ventilation, and starting from basics to the extensive ICU care. So I hope he has enough time to do this. And at the end of this presentation, Dr. Ganesham is going to moderate the discussion. So Dr. Ganesham, over to you before Dr. Srikanth speaks.
Thank you. Thank you, Dr. Chandrasekhar. I would just briefly introduce the panel and then we'll go ahead with the presentation. I should say that the panel has almost all my dear friends. Dr. Mohan Maharaj, who is the Director of Critical Care from Medicover, Vizag. Dr. Bharat Jagiasi, he is the Head of the Department of Critical Care, Reliance Hospital, Navi Mumbai. Dr. Yash Javeri, he is the Head of Critical Care, Anesthesia, Emergency Medicine, Regency Healthcare, Lucknow. Dr. Hemant HR, again, somebody with whom I studied my intensive care, we were roommates together. He's a chief consultant in critical care at Narayana Hrudayalaya, Bangalore. Dr. Mithilesh Raut, he's a consultant in critical care at Medicover Hospitals at Hyderabad. And Dr. Manish, who has been there with us since we started this webinar, who is a consultant and intensivist in charge from Prince Sultan Cardiac and Research Center, Saudi Arabia. Over to you, Dr. Srikanth, and we'll come back to the panel after the presentation is over.
Thank you, Dr. Chandrasekhar Garu, for the kind introduction. Thank you, Ganesham. I thank you all for giving me this opportunity. So, well, it's a long topic, so I'll start going with it. I'm going to start sharing the screen. So the objectives that I want to achieve today, we're going to talk about some basics of oxygen. There's a lot of confusion about what is the partial pressure of oxygen, what is the saturation. People mix them up all the time, especially volunteers and nurses and paramedical staff, they mix quite a bit. And I've seen some physicians also mix them up all the time. So I just want to give a few slides about that. The other big area that I see quite common when I talk to people is mixing up low flow versus high flow. they intermix the low flow and high flow oxygen. Then we're going to go over the different oxygen devices, concentrators, oxygen cylinders, liquid oxygen. Then we talked a little bit about high flow oxygen systems. Then we go over the non-invasive ventilators. I'll try to cover as much as possible on CPAP, BiPAP, and average volume assured pressure support, AVAPS. Go a little bit about prone positioning. Again, this talk is not only for intensivists, so it's I'm going to talk a little bit about mechanical ventilation, what we are using currently here, what has shown benefit in my hospital. So I'll just talk at some silent points about it, and then we'll open for discussion. So here is some of the basics. We all breathe. Ambient air has about 21% oxygen. So when we call about 21%, the remaining is mixed with 78% nitrogen and 1% is other gases. So the fraction of that oxygen in the ambient air is the fractional inspired oxygen, FiO2. We commonly use that term in the hospital. Different doctors keep using it. FiO2 was 30%, 40%. So that's what this means. We are breathing at 21% right now. As you give oxygen, the FiO2 starts to go up. And so this is a brief slide here, which shows how much is the FiO2 in a dry air, which is about 160. When it is humidified, it's about 150. When you breathe in, with all mixes with the humidification in your respiratory system, and it drops to close to 110. When it reaches the alveoli close to 100, and then further down, finally this oxygen is going to mitochondria. That's where you make the ATP. That's how the oxygen flow is from outside ambient air all the way deep into your tissues. Again, so what is the partial pressure? So the air that we breathe in goes to the alveoli. From there, it enters into the plasma, right? The air is first entering into the plasma. From the plasma, it mixes, the air oxygen molecules are bound to the hemoglobin. That's where the saturation is. So when people talk about partial pressure of oxygen, they're talking about the oxygen in the plasma, not in the hemoglobin. When we talk about saturation, we are looking at how many oxygen molecules are bound to the hemoglobin. There's another term we talk about is oxygen content. Oxygen content is the amount of oxygen in the plasma and also that is bound to the hemoglobin. About 97% of oxygen that is carried out in our body in the blood is bound to hemoglobin. Only 3% in this plasma. Why is this important? So this is just a slide showing there are 4 molecules, 4 chains to which oxygen is bound. Why is the concept of oxygen is important is when you're trying to how do we measure partial pressure of oxygen? We can check do a blood gas and we measure the partial pressure of oxygen. Remember, the partial pressure of oxygen is the pressure exerted by the oxygen in the plasma. Saturation is something that you measure with the finger pulse oximeters, where using an infrared wave, you measure the bound oxygen to the hemoglobin. And the total bound hemoglobin, total bound oxygen by the total available binding sites is what saturation is. It is mathematically calculated on those pulse oximeters. That's how you get it. So why is this important is to share the relationship. So oxygen, the partial pressure of oxygen, as it goes up, saturation keep going up. And it is like an S-shaped curve. And when it reaches close to 60 and above, the curve starts to get flattening out. Once it reaches 100, it's a pretty flat. By giving a high amount of FiO2, fractional inspired oxygen, increasing the plasma oxygen does not have any beneficial role because your saturation is 100, because oxygen is carried out in the hemoglobin. So it's once you reach 100%, it is not of any benefit. So that's just one slide to share, and then most of us have read this in the medical school, just kind of a little breather. And another important equation that everybody should remember before we move on to the actual oxygen therapy talk is Alveolar gas equation. We use this quite common to understand. So we normally breathe and the oxygen get exchanged in the alveoli, in the capillary surface by diffusion, right? So how much oxygen was available to the alveoli and how much oxygen is there in your blood when you measure the blood gas. That difference is alveolar arterial oxygen difference. And that is important because that will tell us what was the diffusion impairment. There is a pneumonia, pulmonary edema, whatever has happened. This is very useful, especially on a patient who is not yet on oxygen and to understand how much is the gas impairment. Okay, so this is a simple formula. It's present in most of the calculators nowadays in the apps. So it is going to be easily calculated from just a simple blood gas by knowing the PaCO2. All right, so another important concept is PF ratio, and I'm going to use this PF ratios quite a bit in the talk. So that's why I want to just introduce that. So PF ratio is nothing but what is the partial pressure of oxygen and how much was the FiO2 given. So you get a ratio, and this is especially useful somebody getting oxygen. Let's say, for example, somebody's on a BiPAP or a venturi mask or intubated, and you're giving a fractionally inspired oxygen of 50%, and their PO2 is PaO2, the arterial oxygen that you measured on blood gas is 100. Their PF ratio is nothing but 100 by 0.5. It's about 200. So what does that PF ratio means? Normal is about 300 to 500. So once it goes below 300, 200 to 300, we call mild ARDS, adult respiratory distress syndrome. Between 100 to 200, we call moderate, and less than 100 is severe. So how does this is very easy to communicate with other physicians. Hey, PF ratio is this, so and so. This shows how severe the patient is at this point, right? Again, we'll start here with the COVID. We all know COVID has a typical prodrome for about a week where, they get infected, they initially start feeling fatigued and start to manifest symptoms slowly. After a week, majority of the patient do get better. Close to 80% to 90% of people get better. But there are about 10, 20% that keep progressing further on. They start having patchy infiltrates in the lung. They start to have a VQ, ventilation perfusion mismatch, and but the gas volumes are pretty normal even then. So that's the stage where we call silent hypoxemia. That patients keep progressing on to struggling phase where they start to get more tachypneic, respiratory rate goes up. And eventually these patients can progress. If we still don't intervene here appropriately, then they further go on to respiratory failure, into multi-organ failure and death. So where and what device of oxygen are we using in different stages of the spectrum is what we're going to talk about. Just a slide showing here this is a NIH website, National Institute of Health. It gives you pretty much a decent recommendations as what do we use currently. Again, these are not updated every day, but these are most common sense based on the available literature, and they do give you A to C recommendations. It's a free access, and you can all use this. And a lot of these recommendations that I posted in this talk are from National Institute of Health. And these are the basic oxygen guidelines that I put from here. So all right, let's begin with the goals. Okay, so we want to give oxygen for a COVID patient. So what is the goal? What targets are we achieving here? So we are achieving a target of 92 to 96. Why? Because it is being shown, so anything below 92 is called as conservative oxygen therapy. Anything above 96 is called as liberal oxygen therapy. So there are studies done on this. There was this study, well, most of these studies are actually pre-COVID era studies. So they were done on ARDS patients, they were done on different other pneumonia and cases like that. But they are extrapolating those studies onto the COVID and to the best available literature. So 92 to 96 is the present target because the in the NEGM study in the past has shown that anything target less than 92 is detrimental. More than 96 was also harmful. So it's based on, again, the studies are not the best, but some of them are meta-analysis. I think the LOCO-2 study is a randomized study, so that was very useful. So nutshell, 92 to 96, at least in my hospital, mostly we use 92 to 94 is the target. All right, so next to move on, the type of oxygen devices. So the confusion here is the low flow and high flow. So what is, how do you know what flow is what? So we normally, when we breathe, there is a flow of air. If you measure the flow at your nostril, what is the flow? Is it normal? It's a normal breathing. It's about 20 liters per minute. And when you take a deep breath, it's about 30 liters per minute. Low flow means when you're providing an oxygen device that is not below your normal flow. That's low flow. When you give more than that, that's a high flow. So these are this is commonly intermixed by many. So what are the low flow devices? You have nasal cannula, you have simple mask, you have partial rebreathing mask and non-rebreathing mask. And the high flow devices are Venturi mask and high flow humidified system. So simple nasal cannula can give up to from 1 all the way up to 6 liters. As you can see on the right side, an FiO2 range. For example, 1 liter is 0.24. Now, when you use a low flow system, because the patient is breathing much higher flow rate than what you are providing oxygen. So they are breathing oxygen and they're also breathing ambient air. So nitrogen is mixing up there. So even though the oxygen is 100%, the nitrogen mixes up and then drops the FiO2. So that's why the low flow system are inefficient in increasing your FiO2 that you deliver to alveolar. Compared to these high flow systems like Venturi mask, they can give accurate high FiO2. Right. All right, so then, so now we know what are low flow and high flow. So how do we give this oxygen? So in the hospitals, obviously, you have inline systems. You have walled-in pipes, and then you're taking oxygen from there. Or maybe it's a smaller hospital, you may have to have an oxygen concentrator or cylinder. So let's just talk about those. How do we give oxygen? Or even at home, a patient has been discharged, what do they go home with? So oxygen concentrator, there are the oxygen concentrator that are walled in, like a stationary oxygen concentrator. Like this device is it is walled in, plugged into the electricity. So these are a little bulky, they're heavy, they can weigh up to like 20 to 30 kilos. Compared to the portables are handy, they can be worn on your shoulder. They're very lightweight, about 3 to 10 pounds. Some of them, which can give a higher flow, probably a little heavier. So what is this oxygen concentrator doing? It's taking the ambient air. The compressor, a motor compressor, passes the air through a storage tank, which removes all the impurities, bacteria, virus, and all that. And the oxygen, then it pushes through the sieves, molecular sieve bed, and then it dumps into an oxygen tank. That oxygen is continuously supplied you oxygen. So this is a schematic diagram of a portable, but the concept is the same in either in a stationary or even in a portable. So how big this tank can be will decide how much oxygen flow it can continuously give. So these are just a variety of these are stationary home concentrators. Now, the stationary home concentrators are walled into electricity. You are connected to the continuous electricity, so they generate the oxygen nonstop. The problem with the portable is the advantage is that they're lightweight, they're easy to carry, but they're battery powered, they're not walled in. The whole idea is that you want them to be totally mobile. They can walk, they can do rehab, they can go out. Patients who are discharged from the hospital, what we typically see, okay, does a patient needs oxygen 2 months or 3 months, then they can go home with the walled-in oxygen concentrators with a longer tubing. Well, they have severe pulmonary fibrosis and they need oxygen, portable oxygen. They need oxygen longer term. Then we tend to give them portable oxygen. Portable oxygens are expensive because of battery powered. They're more expensive compared to the walled-in. We give them portable, and depending upon the settings, the more expensive the machine is. But the advantage is that they can walk around, they can do things, they can participate in physical therapy, and this would be useful for patients who have pulmonary fibrosis. What the next is the compressed gas cylinder. So it's nothing but a metal cylinder, and then you push, you store the oxygen in the gas cylinder, and usually you have a regulator and a barometer on the top of it. Regulator is like a tap. You open it, how much ever more you open, you're going to get more flow. So this is a continuous flow. A barometer will tell you how much more pressure is in there. That will describe how much more oxygen is in there. And then we also use, so these are the different oxygen cylinders, different sizes, and they're all graded based on the alphabet M, and the number will indicate how big they are, what their capacity is. So these are the most inefficient way of delivering oxygen because if you're needed a high flow, they can't stand longer. So next is the conserving device. So if the regulator will open up the oxygen, it is continuously flowing oxygen. Now, they find that when you're breathing out, it's such a waste of continuously flowing oxygen. So you have something called conserving device. What conserving device does is it senses when you're inhaling. Whenever you inhale, that's when it will open up and then give you oxygen. That way you can use the same oxygen cylinder longer. Liquid oxygen. Liquid oxygen has a lot more capacity. It is compressed into a liquid, and it can also, the advantage of that is it's the same metal container where liquid oxygen is stored. And the advantage of this liquid oxygen, it can give you high flows. Now, oxygen cylinders cannot give you such a high flow because it won't last longer. Liquid oxygen can last longer, even with the high flow, but they're bulky. You need an oxygen gas company, people to come and frequently change it. Some liquid oxygen companies give you an extra small tank where you can fill it up from the large tank and carry that can stay for up to 4 to 6 hours, where you go into a physician office or something that you can carry that. So that's the advantage of liquid oxygen. Let's quickly move on to the high flow humidification system. Before the COVID, we haven't used this high flow oxygen systems that much. Since the time of COVID, it's a big use of high flow humidification systems. This is also, there was a study, Florali study back in 2017, that made it, that was a very successful use of heated humidification systems. So since then, we have started using the high flow oxygen systems. So what is this? So here, if you see in this picture, you take oxygen through a flow meter, and you have an oxygen blender where you can see how much oxygen, the FiO2, that can be added to the flow. Usually heated humidified oxygen systems can give up to from 10 liters all the way up to 60 liters. And you can adjust the FiO2 how much ever from 10 all the way up to 100, oh, sorry, 21 all the way up to 100. And this oxygen goes through the humidification system and then goes through the interface to the patient. So this interface has a heated circuit where it prevents it from condensation. So these are high flows devices. They can give up to 60 liters. The FiO2 can go up all the way up to 100%. And since it's a high flow, you can assure that's the FiO2 because they are giving much higher flow than what patient is breathing. It is humidified at 37 degrees. Also, you can adjust the temperature this is how and then the interface can be a nasal cannula or even a mask. What's the way it works is because of the high flow and the humidification, it reduces the dead space. And it actually gives, because of such a high flow, if you go back to the physics basics, the flow will create pressure. So when there is such a high flow, you will create a positive pressure. This almost gives you a CPAP of 3 to 5 centimeters of water pressure. It's very comfortable for the patient. And because of the humidification, it does provide airway hydration and obviously supplemental oxygen. It helps with CO2 clearance it prevents desiccation of the airway epithelium. So it can give a stable high FiO2. It does help in recruitment by CPAP effect, humidification. It also flushes the carbon dioxide. So these are the basic advantages of high flow system. Now, a little infection control issue here. Healthcare workers need to understand that these devices, high flow devices, can cause aerosolization of virus particles. So you have to wear N95, have to wear glove, gown, eye protection. Otherwise, there's always a risk of healthcare worker infection. So looking at how do we set up the high flow systems. So there is a study by Ishaki in 2017. We pretty much use the same settings used in that study. So let's say patient on the floors or on the wards using about 6 liters of oxygen, and their FiO2 is their saturations are dropping, and you want to use heated humidification system. Then you start usually with 60 liters, and you can adjust your FiO2 based on maybe 60% or 50%. You go up or down on the FiO2 based on the saturation. The respiratory rate is 25 is the magic number they used. If it is more than 25, they go up to 60 liters. If it is less than 25, they start dropping the flow of oxygen. So they adjust the flow rate based on the respiratory rate. They adjust the FiO2 based on the saturation of the patient. The other important thing to remember with the heated humidification, humidified nasal cannula is watch patient regularly. Don't wait. If your patient is not doing well, intubate them. So that is one of the common reasons why patients this helps in preventing intubation, but at the same time, patient needs intubation, identify based on the clinical situation, bedside, and decide and proceed with intubation if the patient needs it. Don't wait too long. Waiting too long, the patient don't do well. Peri-procedural, they will have cardiac arrest. They will have hypoxemia and cardiac arrest from it. So if the patient looks clinically sick, does not look like high flow humidification or high flow oxygen alone is able to settle the issue, intubate the patient. So there's another question people ask, even my fellows who are in training keep asking this: how do we transport the patients? Because if they're in a high flow systems, they're powered. How do we transport them? Usually use non-remither mask for transporting at 10 to 12 liters or even up to 15 liters. The mask, and sometimes we put an extra surgical mask over that and then transport them. I think we talked about this, the CPAP effect by the heated humidified nasal cannulas. Flushing of carbon dioxide, we talked about this. I'm going to skip through this. It also helps in reducing the work of breathing and with the heated humidified nasal cannulas. Yeah, so if you're interested, this will be a nice article to read. It's a high flow oxygen to reduce acute lung injury in New England Journal of Medicine. It describes very nicely how these have helped. This was back in 2015. I think I said I mistake 2017 last time. So 2015, it was an old study, but this is a nice article to read through, and it gives all the advantages of the high flow oxygen. It's about the same thing. I'm going to skip through this. It's describing the article. So, so high flow oxygen, it's better than conventional. It has shown in the Florali, the previous study that I was quoting, better than non-invasive ventilation in hypoxemic respiratory failure. But one caveat to remember: if the patient looks sick, tachypnic, increased work of breathing in spite of oxygen saturation is normal, intubate the patient. And if there is signs of shock, intubate the patient. All right, let's talk a little bit about non-invasive ventilators. So we're going to talk a little bit about CPAP, BiPAP, and a little bit about the AVAPS. In general, non-invasive ventilators, the concept is they increase the FRC, functional residual capacity, thereby they helps in recruitment of the alveoli. That means recruitment, as a sense, opening up the alveoli, and it helps in better oxygenation and reducing the work of breathing. All right, so CPAP stands for a continuous positive airway pressure. So how does so just a little basic concept of what they mean. So normally we breathe at 0, or sometimes even it becomes negative. Imagine putting a probe in your trachea and measuring the pressure. Normally when you inhale, your pressure goes negative. So it may be -2, -3, and when you exhale, the pressure goes positive. So same way, if you put a CPAP on, you see that when you're inhaling, so let's say you gave a CPAP of 10. So your pressure is constantly given at 10, and you're breathing there. Now normal breathing will be here at 0. And the CPAP, you're breathing here. When you inhale, pressure may be maybe 8 or 7, and then when you exhale, pressure may be 12, 13. So whereas BiPAP, the bi-level positive airway pressure, it gives you 2. Bi stands for 2, right? So bi-level, in inspiratory, when you inhale, you get one pressure. When you exhale, you get a different pressure. So let's say, for example, here it's a BiPAP of 15/5. When you inhale, it gives you a positive pressure. Compared to CPAP, when you're inhaling, it's actually giving negative, right? You're inhaling from the constant pressure. BiPAP, as soon as you inhale, the valves open up and pushes the pressure. So that's the inspiratory pressure here. And then when you exhale, it opens up another valve. So this is the BiPAP. The BiPAP is a little bit more comfortable than CPAP because in a CPAP, you're constantly exhaling against a positive pressure. But in reality, that's what we want. When you exhale against a positive pressure, we create recruitment in the alveoli. So that's why CPAP has been shown more beneficial than BiPAP. BiPAP advantage is it is a little bit more comfortable. It can generate more tidal volumes because you're creating a differential pressure of inspiration and expiration. you generate a higher tidal volumes and minute ventilation in a BiPAP. So this is another picture showing the same thing. Another concept is, so I'm going to talk a little bit in the next slide, like when do you use CPAP, BiPAP, and AVAPS. But just AVAPS, just a little nutshell here. So in AVAPS, it's nothing but a BiPAP with an assured volume to it. You can set up how much tidal volume can the machine give within the range of pressure. So let's say, for example, here in this setting, they gave 500 tidal volume, and they set minimum pressure 10, maximum pressure 20. And then it's like a EPAP, which is like in the BiPAP, IPAP, and EPAP. So the I is nothing but the minimum and maximum. The EPAP is the 4. So in addition to the BiPAP, the extra setting is the volume. So a machine assures that it will give 500 ml, utilizing the inspiratory pressure of between 10 and 20. So that's the AVAP. Where is it useful is, let's say a patient has a neuromuscular disorder where they don't breathe well, or restrictive lung disease, or obesity, hypoventilation. They're very shallow breathers. Their tidal volumes are slow. And their partial pressures of carbon dioxide are high. You want to use AVAPS in them because the beauty of this is you can set what minute ventilation you want on the patient. So the AVAPS is good on them. Okay, so when to use these different modes? So CPAP by far is the most commonly used for our COVID patients. BiPAP, if let's say a patient has sleep apnea or in a condition where they're already on BiPAP at home, continue the same settings on the BiPAP. You don't have to change. Or let's say the patient has neuromuscular disorder. Their history is suggestive of some muscle fatigue and neuromuscular disorder or obesity, hypoventilation. Go ahead and use AVAPS on them. You don't have to change that. But if it's a young patient who's coming in, on the floor on 6 liters of oxygen, milder respiratory distress, you can try CPAP on that. It will help in recruitment of the alveoli, will help in better ventilation perfusion matching. But caveat is, remember, clinically monitor them closely, and if they need to be intubated, intubate them. Okay, so the other important caveat here is, again, I'm not sure how much time is available, but there is a nice article by Gattinoni where they describe L-type and H-type. So L-type is whenever patient comes in with a good lung compliance, they're L-type. They progress on as they develop more ARDS to H-type. So between L-type and H-type, it's a dynamic change, and we don't know when they change that. So ideally in L-type, that's when we have silent hypoxemia, you want to use oxygen, maybe CPAP. But when you try to push them, when they're heading towards H-type, there is a concept called patient self-inflicted lung injury. They start using high tidal volumes, and they start getting polytrauma. There's a concept called malignant atelectasis. The higher the alveoli that are stretched, the in-between alveoli get atelectasis. In addition to the COVID-related inflammation and atelectasis and hydrostatic pulmonary edema, in addition to that, you also have the volutrauma from BiPAPs and the even heated humidification system. By just prolonging the patient in respiratory, patient workout breathing is high, and you let them keep going on with CPAPs, BiPAPs, or Optiflows, or the heated humidified nasal cannulas, they will get into PSILI. Avoid PSILI at all costs in patients. And if they are on the wards, they are deteriorating, they may need intubation. So CPAP helps in recruitment of collapsed alveoli. I think we talked about this. Yeah, and another thing is maybe an old patient, 80-year-old or functionally 80-year-old who does not want intubation, and you just have to keep them going with whatever possible means. He's do not resuscitate, that does not want to go on a ventilator. You can use CPAP, and if their minute ventilation is low on the CPAP, you can go on to BiPAP or AVAPS. That would be one condition for sure. You only can use these devices because they don't want to go on a ventilator, and that's fine, and that's it. And another thing that we commonly see is patients who are very tachypneic because of anxiety-related issue, being on the mask with the BiPAP or CPAP. We use Presidex, dexmedetomidine IV infusion on a continuous drip, and that's seemed to control the respiratory rate. We also use narcotics, any of the fentanyl or that can be used. We avoid benzodiazepines that much, but we use these dexmedetomidine has been very useful. Yeah, so what pressure of CPAP we normally set at? So we usually set at a little higher pressures between 12, 10 and 12. But you go, the goal again is keep measuring their minute ventilations, whereas the goal is 6 cc idle body weight. That basically like around 350, 400 ml that you're getting. Minute ventilation are about 6 to 8 liters. As long as they're there, that's perfect. And when you're managing all this, again, remember the infection control, N95, glove, mask, gown. Okay, so just one slide just showing that CPAP is preferred. BiPAP can cause the patient's self-inflicted lung injury. Please avoid that. Again, this is a slide showing how far does the aerosolization spread. For example, a non-rebreather mask, it's at least about 5-10 centimeters. Heated high flow systems up to 10 to 12 centimeters. Nasal cannula close to 35 centimeters. And with the positive pressure, you get almost 100 centimeters. So high with the NIVs. And even with the nebulizers, it's high. So that's why in most of our COVID patients, we just give inhalers. We give like an albuterol inhaler, and if you feel like they needs inhaled corticosteroids, we give any of the long-acting inhaled corticosteroids, formoterol or fluticasone combination inhaler with the patient, and they can use twice a day instead of nebulizer, just for the healthcare worker safety. Again, this is another algorithm, how we start with the patients. So we get a mild COVID patients. Initially, we start with oxygen, as they're with an escalating dose of oxygen, go up to 6 liters. And then they continue to have worsening hypoxemia. Then we try to use the high flow nasal cannula. And then we start looking at their PF ratios. And if their PF ratios are worsening, or if their workup breathing is high, you can start with the CPAPs. But if they continue to get worse, then we consider transferring them to ICU, and intubation may be needed. So this is just an algorithm showing the same thing. This concept of awake proning. So proning.
Srikanth, sorry to interrupt, but we need to have some time for the discussion. So if you can just wrap up a little.
You kind of cut off earlier.
No, I mean, we just, sorry to interrupt you, but we also need some time for a discussion as well. So if you can just
okay.
move on. Yeah, sorry.
Okay. Okay. Yeah, so awake proning, the most of this concept came from the previous ARDS literature, and when you prone somebody, the usually when you're supine, a lot of the areas in the posterior lungs are atelectatic. That's where most of your circulation is. And by proning, you create a postural drainage. You increase the recruitment in the posterior side of the lung. And also the FRC gets better when you prone, because in the supine, the heart and the abdominal contents pushes and reduces your FRC. By proning, you increase your FRC, and that helps. Again, this proning came from ARDS literature, but that has been useful in awake patients. Your oxygen saturations will help, obviously, with the better recruitment in the posterior segment of the lung. With the better VQ match, you're able to better oxygenate, and their saturations do get better. So how do we prone? We usually use 3 pillows and use the reverse Trendelenburg position. 1 pillow on the head, in the pelvis, and on the legs. Reverse Trendelenburg, as called as a swimmer's position, with one hand on the top and then the other one on the down, as is shown on the picture here. Again, the contraindications to use, keep checking the patient. On the awake proning patients, their PF ratio does get better, but if they are going towards respiratory distress, consider promptly taking them to the ICU and intubation. And they have to be alert. Don't do this on a patient with not even having good mentation. It's very hard to keep them prone for long. So we try to, there's an alternative method proposed in the previous literature here, and mainly used in New York at that time. So it's a 2 hours of laying on the prone for 2 hours, on the right side 2 hours, left side 2 hours, and then sitting 2 hours. So then they keep repeating the same thing. So this is an alternative way to handle this. Is it better than complete proning? No, but this is better for patients who cannot tolerate only proning. How long we prone is about 12 to 16 hours. So the ventilator, I will try to skip this to leave more time for discussion. Just a few things. The ventilator is, again, we can use the ARCHNet protocol, but there is the better way we use is the same ARCHNet kind of a protocol, but try to measure the driving pressure. Driving pressure is the plateau pressure. You know, when you use ARCHNet, you want to keep the plateau under 30 centimeters of water pressure. So when you keep the plateau under 30, you adjusted the PEEP, measure the compliance of the lung, measure the driving pressure, adjust your PEEP based on, even though you started as a ARCHNet protocol, but adjust your PEEP based on the driving pressure. The goal of driving pressure is between 14 to 18. APRV can be used as well, because the concept is inverse ratio ventilation. Propofol we use mostly, or Versed and fentanyl for sedation. And obviously, if there is a ventilator asynchrony, use the neuromuscular blockage. One other thing I want to touch, just a few slides here, is inhaled pulmonary vasodilators. The NIH have recommended against use of pulmonary vasodilator for all patients, but what I would suggest is to look at if they have any signs of RV dysfunction on the echo, and then if you find anything, obviously this will help. And patients, especially who are already on a ventilator, who are on 100% FiO2, high PEEP, you still cannot get their oxygenation up. You can use inhaled pulmonary vasodilators, and especially if you have an evidence of pulmonary hypertension or an acute RV dysfunction. So we use either epoprostenol or inhaled nitric oxide. ECMO, again, it's talked about heavily, but the ECMO is only a bridge. It's not a treatment by itself. So we are trying to give some time, and if the patient has severe ARDS, where obviously ECMO is only a bridge where they need to go on to a lung transplant, because ECMO alone is not going to cure anything. Consideration is if they're a young patient, if they have a single organ failure and they're L-type ARDS, or they have an organ available, and they are under mechanical ventilation less than 7 days, you can consider ECMO, but it's a very limited. In the previous articles that are published back in 2021, this Journal of Cardiovascular Anesthesia, mortality was close to 100% on all ECMO patients. So it's not very preferred, but it's available. All right, that's all I have. We can open for discussion, Ghanshyam.
Thank you, Srikanth. I invite all the panelists to be there with me. Can I request all the panelists to please unmute?
Yes.
Hello, Manish.
Hi, how are you?
Mohan sir, good evening.
Hi, sir. Good evening.
Thank you, Srikanth. I mean, for a very extensive and elaborate, discussion about the concept of oxygen therapy and the various techniques by which we can deliver oxygen. And oxygen, we have been using oxygen since a long time. But of late, it has been in the news for various, good or bad reasons, allowing the highlight in various media channels as well as the newspapers. I would like to open the discussion with Mohan sir. Sir, you have been somebody who has not only been on both anesthesia and intensive care side, but also an administrator, right? And we have faced a situation where there was a lot of oxygen deficiencies, or there was a shortage of oxygen. What were your thoughts, or what would you suggest? I mean, how do we deal with this kind of situation? Probably one of the things that Srikanth did suggest was to look at our oxygen targets very closely. I mean, there is something that we need to look at. So, Mohan sir, your thoughts on that?
Sir, it was a really panic and situation that people are dying in front of me, and which I'm not able to take the patient inside the hospital and outside in the car with the oxygen cylinders in the ambulances. A lot of deaths which I have noticed and myself witnessed. So main thing was I made a separate training for all the technicians. Their job is to go and see the target is only 94% in the SpO2, not more than that. Simple target. The second thing, as the speaker has extensively, very nicely elaborated and told how to really, because non-rebreathing mask is better, because once you're taking the breathing, then only oxygen comes, otherwise it goes back to the bag. That's useful benefit. But there is a dangerous that you are using at least 8 liters. Most of the people are using the oxygen with the fear of they may be having a problem. Actually, they don't need oxygen. So for that, I used to go to every patient and ask them to open the internet and ask them to read the oxygen toxicity and start it. The second point was whenever they are putting oxygen nasal prongs, as the speaker is nicely depicted properly with this, and I put the oxygen mask over and above the nasal prongs, so that the feeling of better is there for the patients and automatically concentration increase. That I've noticed very clearly, which is a less cost effective. So he has the feeling that he has having 2 connections, but only 1 is sufficient. So the target is 94 is the maximum, and particularly change it to the oxygen concentrators and to the liquid oxygen, because most of the people to reduce it to the room and ask them to get it for a rental and cut off. Another challenge I had, even recently I joined for a Medicover Hospital in Visakhapatnam. This is 8 floors building, which is the pressure has to be maintained. So regularly night 1 o'clock, 2 o'clock, we need to go and see the pressures down. Otherwise, so many people are dying because of suddenly in the midnight 12 o'clock, they change in the liquid oxygen and oxygen concentrators and the cylinders changing. That will fall, and the people who are on FiO2 to more than 80, 90, they were really going into the hypoxia. So we have closed almost 3 to 4 floors above for oxygen and tried to build up in a better way in this one. So this is all take from my side. Thank you, Ghanshyam.
Yeah. Any thoughts from any of the panelists? I mean, we have used the Bain circuit being used. My biggest concern is the kind of the work of breathing that would be induced with that, and the fact that for that kind of a circuit to work, you need to maintain a very high flow. Manish, yes, I'm sure you would have seen the Bains being connected to patients with a BiPAP mask, and people have kind of swayed in that it's working. Yes, Manish.
Yeah. See, all these were desperate measures, and Bain circuit could create some CPAP-like effect that was discussed by the speaker also. So that was the only motive behind it, and we had very limited or no resources. So we resorted to extreme measures in extreme situations. But the physiological basis was some CPAP effect.
Manish? Mute, mute, up mute.
Thank you, Ghanshyam. Thank you, Srikanth, for giving such a wonderful talk. Although I would be keen to listen more onto the aspects which the Srikanth has discussed. See, Ghanshyam, we were lucky in this sense that we have not used this kind of the modified versions of the vein circuit and all those kind of a treatment. I always believe that oxygen is a drug, and then there has to be an indication and there has to be an effect as well as the side effects. So we were quite conservative in terms of using right from the very front, because we believe that whatever the things we are using, it's going to also create a lot of side effects as well. So I had no experience in using the vein circuits as such, because we were very clear that we were having a quite liberal setup in terms of the kind of infrastructure we were having in Kingdom of Saudi Arabia. So maybe that was the reason that we were lucky in that sense.
Hemant, have you ever come across that, or have you used that? I mean, how did you deal with it? Hemant, you're on. Please go on.
Yeah. So, Ghanshyam, luckily we were not pushed to that extreme situations this time. One of the things that we did was stick to the saturation targets, and our respiratory therapist, one of the main job of respiratory therapist was to ensure that the saturation targets are met. And our saturations were 90 to 92% in the first 1 or 2 weeks, and those patients who were still stuck on ventilator, or on 3rd week and 4th week, we even accepted a saturation of 85%, and some of them even went home on home oxygen. So I would say that the saturation targets were a little flexible depending on the disease trajectory, whether it is 1st week, 2nd week, or 3rd week and beyond.
I'm sure all the panelists would agree that the oxygen saturation targets that we just discussed would not apply to everybody. For example, patient pregnancy comes in. I'm sure that all of you would agree that we need to maintain a slightly higher saturation. Similarly, a patient with probably a neurological insult comes, patients with either a stroke or a big comes, probably you would try to maintain a slightly higher saturation than the accepted saturation target of 88 to 92. Mithilesh, rest of the panel, your thoughts on these exceptions?
So we always try saturations, and we try to keep the saturations around 92%. And depending upon the respiratory distress, or depending upon that, we titrated our oxygen. We didn't use any new method, but we try to aggressively awake phoning patient, mobilizing them, and that was how we dealt with the situations. We didn't use anything new. We stuck to our old basic things only.
I will come to awake phoning later, Mithilesh.
One question.
Yes, Manish.
See, Ghanshyam, what is important to understand that what we have learned from the COVID, that maybe we were quite liberal beforehand, and as the COVID we have seen that so quite conservative. The strategy has been proven as the fruitful for majority of us. What we used to do that rather than taking just oxygenation into the as a main target for deciding what should be the strategy, we also used to see some the viable parameters, like seeing the lactate. So if you have some measurements apart from the oxygen which can suggest that exactly the patient is having a cellular the hypoxia as well, so that becomes used to be a quite indication for the patient to increase the reasonable threshold for the oxygen supplementation. But as long as we were used to see that the lactate and other parameters, they were stable for, I'm talking about the sick patients, so we used to go down to as low as the 87-88% as well.
Yes.
Yeah. See, we have to understand how low is low, and we have been discussing this for a long time. Does hypoxia kills? I think it does not kill. And it is the first time in my life where I saw a saturation on a plethysmograph of 0. 3, 4, 7 we have been seeing for months, but I saw 0 with a blood vessel and a heart which was functioning. So hypoxia does not kill acutely. So targets can be lowered, but what are the effects of these lower targets on long-term outcomes has to be seen with the case control study in coming years. The targets certainly were 87 to 89 depending on case scenario, and there were some scenarios like MI, pregnancy, brain injury, polytrauma, bleeding patient where the targets were little reasonable, little higher, like 94 to 96%. Otherwise, for vast majority, it was 87, 89% for us also.
Okay. So I mean,
To the panel, what I would like to share is, and I did talk about this in the, again, desperate situations are a little bit different than when you have a luxury to do different things. But just one thing that I want to share here is this study that was done in I think it's 2018 or 2020. This is on ARDS patients. As you see on the slide here, it was actually a randomized study, and the trial actually was stopped because of futility. What basically they divided into two groups: conservative oxygenation and liberal oxygen. The conservative targets were 88 to 92, and the liberal targets were more than 96. They clearly saw a high mortality in a conservative group at 28 days. Now, the death is from all cause. Again, in this article, they described in specific as what was the cause for death and everything. But what the author described is definitely with the conservative strategy, there was a high mortality seen in that study. And this is actually, it's a small group, it's 201 patients. But just they saw more mesenteric ischemic events with the conservative strategy.
Yeah. So let me put one more point here, Ghanshyam. So there are effects of hypoxia, and acute hypoxia is obviously different from chronic hypoxia. Like people who are living at high altitude, they are chronically hypoxic, but they are acclimatized to it. So what effect would low uncorrected hypoxia will have on long-term physiological effect has to be seen. Another point, hypoxia fuels coagulopathy. This is again which has to be remembered, especially while we are looking at a very, very procoagulant state and where we talk about cytokine storm. So hypoxia and a coagulopathy will be fueling each other also. But yes, as everyone is doing, our targets were much lower, 87 to 90% most of the time.
Yes, Raghu.
We are seeing more number of severe hypoxic respiratory failure requiring continuous NIV or HFNC. So many of us are developing pneumomediastinum, pneumopericardium, and all that. So in that case, I mean, what would be the best way to prevent, or if already said pneumomediastinum, then requiring NIV? What next options or?
Yeah.
This is again something that we have seen very commonly this time. Probably more amount of paratrauma or pneumomediastinums this time air leaks than as compared to the first time. Yeah, your thoughts?
Yeah.
Hemant?
The reason for these pneumomediastinum and are usually the PSILI effect. That's what I was trying to share earlier. As a patient self-inflicted lung injury, it is because the patient starts to breathe fast, and then they're also giving a positive pressure. There is a high risk of volutrauma and pneumothorax, pneumomediastinum through that. And those kind of patients shouldn't have been on non-NIV at all. They should have been intubated long back. So that again, there is a misconception saying patients are intubated, they're going to die. Not necessarily. If you intubate them early, and they can be totally salvageable. Where if they intubate them late, much late in their ARDS, they're not going to have a good outcome. They obviously will have a bad outcome. Yeah. But if they're intubated early and then use a proper protocol, they can be extubated and do fine. But if you intubate them late in their ARDS with the PF ratio less than 100,
I totally agree with you, Srikanth. I think there is absolutely no debating the point that delaying intubation is not going to lead to anywhere. If the patient needs intubation, please go ahead and do it. Early tubing, early phoning is the way to deal with patients with severe respiratory distress. The problem comes when a large number of patients present to you very, very late, right? They spend some time somewhere in different hospitals, and then they come to you in the second week, third week on an NIV, and consistently our observation has been the moment you intubate them, within 12 to 24 hours, they are crashing. I mean, I would like to take the opinion of the panel on this. I mean, before we go to the reference.
Yeah, I will go to the first question again. Pneumomedicinum, the choice of oxygen delivery devices we used to give high flow oxygen. Why high flow oxygen? Because there is air in the pneumomedicinum. We want. Then the escalation ladder was HFNC, but again we have to remember HFNC also increases the mean airway pressure. Then we don't know whether NIV is that bad or invasive mechanical is bad. There is no head-to-head trial in invasive mechanical ventilation and NIV on outcome of pneumomedicinum. And we have thousands and thousands of pneumomedicinum, all of us. So putting all of them on mechanical ventilator could not have been a good choice, and it is still not evidence-based.
Manish, Hemant.
Yeah,
I think Ghanshyam, Dr. Bharat want to say something since very long.
Bharat,
yeah, I can.
I sorry.
Not
Yeah.
I saw him a couple of times, so I thought let him first address.
Yeah, I think this view
Thank you,
is.
Manish.
Yeah.
So Ghanshyam, I mean, as Manish said, so I'll start right from the beginning. So first was from the hypoxia point of view. So hypoxia, as we all see how bad or how good is hypoxia is going to be. So how we look into it and what the discussion is going on is we look into the numbers. That's 90s and hypoxia, the 85s and hypoxia. So so that is not the right way of looking at it. As Manish rightly pointed out, we have to have some parameters. So lactate is one of the good ways when we do it. So you see if there's no hypertension, there's no hemodynamic instability, and still you having a saturation of somewhere around 88 and your lactates are stable, you accept that. But with saturation of 88, your lactates are going up, and those improves it when you just increase a little oxygen to 90, 91. So that means in that case, 91, even 89 is an hypoxia. So that is a way of doing it. Then as Yash said it, hypoxia doesn't kill. I don't agree with the Yash. Hypoxia do kill and does kill it. So, and plethysmography, you go to any of the instruments. So they usually don't test it less than 75. It's an ethical issue. So below those levels, the calibration is not there. So it's very difficult to how bad or how good it was. Regarding the pneumomediastinum, I agree with Yash. When someone has a pneumomediastinum, so whether you put that patient on NIV or on the invasive ventilation, again, it's a positive pressure ventilation both ways. So see.
Yeah, Bharat and Manish, both of you mentioned about lactate. I just want to play the devil's advocate here. Just want to tell you or get to this point that lactate may not always point towards hypoxic metabolism, right? We also know that when there is severe sympathetic drive, you can still have elevated lactase and they may not point towards hypoxia. I'll leave that point there.
This is why I said, you have to be sure there's no hemodynamic instability, no other things around.
No, Ghanshyam, see, what we need to understand, there's no magical figures. When it comes to the guidelines, you know what Srikanth has talked about. This is something which we do it at a broader scale. There has to be some form of, the targets which has to be given for majority of us to follow. What Bharat and what I'm trying to say that as an intensive care people, you have to really reasonably, you have to, give them the individual targets for your patients. Obviously, if the patient is having a lot of comorbidities and you find that the patient, let's say the patient is having a saturation of 92%, right? But despite of this thing, you find that the lactate is relatively onto the higher side. You suspect that the patient is having a high capillary filling times. The patient is having a, the disorganized in the perfusion markers. So in that kind of a setting, you have to be reasonably high. So my point is very simple that, you still have to go ahead with, the patient titrated therapy. It has to be individualized as far as, the intensive care practice is considered. But yes, when it comes to the broader aspect, when you have to talk about at a larger scale, as Srikanth has said, definitely we have some, few of the targets which are available to us. So that is one. Now, as far as I would take one opportunity, the Ghanshyam, because I will differ in this, as far as air leak syndrome is considered. See, I completely agree that, as Srikanth has said, we need to understand that this is a reflection of self-inflicted lung injury. Unless and until you control the patient, the breathing pattern, this is only going to get worse. So the one point is very simple. Whenever the patient is developing any kind of features which are like pneumomediastinum or the pneumothorax or whatever the stuff, this is something which is a reflection between the supply and demand mismatch. Somewhere the patient is hyperventilating, their swings into the intrapleural pressures, they are massive. So unless and until you are really going to control them right then and there itself, this is only going to have one fatal outcome. So there is, I'm yet to see a patient with a pneumomediastinum and they are surviving and they are coming out well.
Manish, could it just mean that not only just CPAP, the pneumomediastinum and the pneumothorax that happen could also indirectly indicate the severity of the lung injury?
Yes,
because we have kind of seen this even in ARDS with H1N1, where the concept of CPAP did not, was not even, brought to the kind of discussion. So probably it's indirectly an evidence that there is a severe lung injury which is happening.
No, Ghanshyam, what he said is very right. CPAP and you have to control breathing. So someone who is breathing very high, even on NIV, that patient is anyways going to get intubated whether there's a pneumomediastinum or not.
See, Ghanshyam, let us understand that, the ARDS, I normally call it as an iatrogenic disease. There is a reason we need to understand. See, we fail to first ventilate them. And then we expect, the patient to get, the normal, despite of having a lot of, the PSILI or, whatever the kind of, I also call that, the non-invasive is responsible for VILI as well. So if you see, you're putting a patient on non-invasive ventilation with uncontrolled kind of, the pressures, and then, your tidal volumes is going as high as maybe a 800 ml and something, So expecting a wide change in your swings into the intrapleural pressure and inviting a lot of, the increase in the capillary permeability in the, the extravascular, the lung water index, then obviously, the patient who was initially L variant is going to become H variant. And then we say that the patient has actually worsened because of, the progression of the disease. So try to understand, I'm not denying this fact that the patient is having a nidus of the disease, but why do the patient from the L variant has gone into the H variant? That is something where we have to see. This transition is something which has to be controlled by the intensive care people. And this transition to some extent can be controlled.
Dr. Manish, I think that's what Dr. Ghanshyam is telling from the beginning, early intubation. I think that itself is the answers that.
No, not that. I'd like to come in, Ghanshyam. Just give me a chance.
Yes, Bharat.
See, whatever Manish has said, tidal volume more than 800, minute ventilation more than 15 liters, someone who's really tachypneic, and on NIV, those patients are anyways heading for the intubation, whether yes or no. What we are trying to tell you here is someone who has a discussion is someone, those are anyways heading for the intubation, whether there's a mediastinum, yes or no. But someone who's on NIV, breathing a rate of 27, 26, generating a volume of 450, minute ventilation somewhere around 11 to 12 liters. When we say mediastinum has to go for the intubation, this message, even those patients will go on intubation. But someone in NIV, if there's no mediastinum generating a volume of 800, minute ventilation more than 15 liters, maybe breathing a rate of 35, I will intubate that patient.
See, why do we are seeing this kind of problems in the second wave? We need to understand, because we failure to control their controlled breathing pattern. I'm not against that.
Manish, I think I don't think any of the panelists disagree on this front that if the patient has severe ARDS, early intubation is needed. I think a large number of centers, resorted to trying out NIV as a desperate measures because of the increased workload, maybe the shortage of ventilators, probably relying and hoping that maybe the NIV works. The message I think is loud and clear from the entire panel that do not rely on NIV for too long.
I will put a comment here, Ghanshyam. See, we have to be contextual always. Okay, we do not have facility to ventilate might be 10 lakh patients, so we cannot go for it. And there is no head-to-head trials. Remember this thing. Have you gone through a head-to-head trial? Any one of us? No. Third thing is, till the time patient develops pneumonia, it is almost 8 to 10 days. Am I incorrect? No. So already the patient has been generating large volume. So if there is 1 or 2 odd patients in our ICU, we would have gone by the textbook. We might have intubated the patient, might have controlled the tidal volumes, but this is not the case. We are in the worst case scenario. So we have to be contextual in our practice.
Bharat, I do agree with you. This is something that I have also seen. We have come across a large number of patients who are very comfortable breathing absolutely at 20, 21, 22, generating 400, 350 tidal volumes, and they kind of go slowly day 5, day 6, day 7, probably because of the natural progress of the disease. I'm sure most of you would have come across this. Your thoughts, Manish, on that? So how do you decide when would you intubate? If the patient is comfortable, right?
See, let me tell you, Ghanshyam, if you see that, I understand, what Dr. Yash has said, that you have to be practical at times, you have to see the burden which we are dealing with. Overall, it's an enormous burden. So obviously, it's not practically feasible to tube every patient and, just get, the desirable measures. But at the same time, see what I'm trying to say, Ghanshyam, we first have to understand that what is correct for them. If the patient is having a refractory hypoxemia for whatever the reason, unless and until you are going to control their breathing pattern, you will have, the adverse outcome, whatever hard you say. Now, as Dr. Yash has said, whether we have any head-to-head trial, see what head-to-head trial we are looking for. We are very much clear that, the concept of PaO2, the patient-induced self-inflicted lung injury has come into the picture because of the same reason. And that is why, the propositions has come that, you have to give them a controlled low tidal volume ventilation strategy in the initial phase itself, so that eventually the transfer from L variant to H variant should not happen. Once they land them into an H variant,
Manish, but when we diagnose pneumomedicine, it is already 7, 8, 10
No,
days.
I'm saying the same thing. I'm saying the same thing. See, there is two things we have to understand. One, we are talking about first what we have to do in the initial setting, right? So if you're talking about the initial approach for the patient, where the patient is having a refractory hypoxemia, and you feel that the patient is having a quite high swings in the pleural pressures and all, I'm talking about that strategy where you should try to give them a control, the ventilation. Let's say, as Dr. Yash has talked about, that the pneumomediastinum already happened. So that's why these kind of a patient, they will have bad outcome. As simple as we have to understand. You cannot change their outcome.
One question to all of you. Question to all of you. Would you try NIV? Second, if you want to try NIV, what is the time frame that you would look at where you will shift from NIV to intubation? And how would you decide? Bharat, Hemant?
I'll see that.
Bharat, yeah. Hemant, Bharat, one by one.
Yeah, please.
Hemant, please go ahead. Go ahead, Hemant.
See, Ghanshyam, you raised a very important point. See, when we use NIV for type 2 respiratory failure and when we use NIV for type 1 respiratory failure, the way we look at and follow up is totally different. If you use NIV for type 1 respiratory failure, you need to understand when to give up. Unfortunately, we put patients on NIV, we set a saturation target, and then we leave it to the nurses or the respiratory therapist to follow. But unfortunately, there's something which they miss, that is change in the respiratory rate, change in the breathing pattern, use of accessory muscles, how fast they desaturate when they are being fed and when the NIV is disconnected to give them water, etc. These are all subtle things, which you should observe. And when these are happening, you should know when to give up. Accepting defeat at NIV and when to intubate is a decision which should be properly done. If you just leave for saturation targets on the monitor and titrate NIV just based on saturation, we'll end up delaying intubations, which will probably have adverse outcome.
Bharat.
Yeah, what I was going to tell you, Ghanshyam, when we were at the peak in my unit, in first wave, we were ventilating around 22 patients, and that is in the first wave. And in the second wave, we were ventilating 36 patients. So obviously, number one reason, the second most reason was because second wave was so overwhelming, we didn't have that control. So maybe in the first wave, the patient who was on NIV, on 100%, I was still observing that patient. The second wave, we didn't have that kind of luxury. So we will little bit early intubate, or you can say timely intubate, which were delaying in the first wave. So if I have to go with the Manish, though we intubated early, though we intubated timely in the second wave, because we didn't have that kind of a bandwidth to monitor those patients very closely, still the incidence of pneumomediastinum was high in those patients. So this was something concerning, not because it's delaying intubation or something, it was something concerning with the disease. This is what my take is. And obviously I'll put the patient in NIV, and the reason for converting from NIV to non-invasive would be, again, as I pointed out, if someone is really breathing heavily with very high volumes, high minute ventilation, or is tachypnic, and who is just not maintaining hypoxia in other terms, even on the NIV, those patients will go for the intubation.
Yeah, Manish.
Ghanshyam, can you add? Can I just?
Yeah. Yes, Srikanth. Yes, Srikanth.
Okay, so I'm just going to share screen again. One item here. Coming to what Dr. Manish spoke about and Dr. Yash spoke about, it is one of the very hotly debated topic: when to intubate, what are the parameters to intubate, and a patient and a COVID patient. And there are several articles out there for timing of intubation and things like that. This is a few articles that I put in. There are several other articles also in terms of timing of intubation. In Gattinoni's, we talked about L type and H type. So these are also important. And what Dr. Heyman spoke about is a very subtle science to do a bedside examination and deciding when to intubate. That is the most crucial thing. And I think I agree with Dr. Bharat also. It has to be carefully monitored. At the same time, we have to be judicious about resources and where we can use it. I just wanted to share these articles that are already available as when you can intubate, when to use an IV. But totally relying on NIV would be a bad thing, is all I wanted to say.
So, Ghanshyam, I'll take one opportunity to ask one question.
Yes.
Equal severity of disease. How many survivors you have in NIV group and in an invasive group? Everyone.
Come back again. What was it? Yes.
Sorry. What is the question?
Equal severity of disease. How many survivors you have in invasive versus non-invasive? Not only non-invasive, HFNC or NRBM. Equal severity.
No, we did not practice that way. I mean, someone who required an intubation in terms of we switched to
Yeah. I agree with Bharat. I think it would be a wrong way of postponing the intervention in the case and just wait for the patient fall into the severe category of ARDS and just keep on stretching them on.
The question, I think you are missing the question. Equal. See, we had limited ventilators, all of us. There is no doubt about it. If we would have more ventilators and more resources, many more patients would have been intubated. There is no doubt about it. This is the evidence-based thing, and we would have practiced it. But we had limitations. All of us know this, and all of us were limited by human resources, by ventilators. So the question is, many people were not ventilated actually because of lack of ventilators. So what were the outcomes in those both groups?
No, God forbid, I did not come across that kind of suggestion.
Yes, you only give the answer.
See, no,
I had more survivors in the non-invasive or HFNC group. Distinctly more.
No, again, Manish, we need to answer few more questions.
No, I have 2-3 things just to add, because see, the first thing which I have to speak when, the Yash has asked for what would be the survival, So obviously, if I have to talk about, the my working unit, definitely the patient who has received the standardized, the care in the form of, if the patient is having a mild to moderate ARDS, you give them NIV, HFNC, whatever the stuff you like. If the patient is moderately severe, where the PF ratio is less than 150, we have learned the lessons from the previous segments. So if the PF ratio is less than 150, along with, you find that the patient is having a constitution of respiratory distress, please do not hesitate them to intubate and, ventilate them. This is very,
Manish, I don't think anybody is debating that if the patient comes
with respiratory distress. On this.
Yeah, no, I don't think anybody. Hemant.
Just a small, this one, answering his questions. Those patients who remained on NIV and ultimately got better, I saw a higher proportion of patients requiring home oxygen. This is our institute's this one. That's I thought.
I agree totally.
I think all the panelists agree on one part. See, I'm sure all of us have been in intensive care. We have never actually debated, about early versus late intubations in early ARDS patients when the numbers were not so high. I mean, I'm sure all of us would have agreed with the fact that if a patient comes with respiratory distress, you wouldn't give NIV for a long period of trial, maybe a couple of hours. Doesn't work out, you go ahead and intubate the patient. But the circumstances were difficult. But I think the message should be that even in difficult circumstances, if your patient is not getting better with NIV within a couple of days, choose them early.
Yeah.
Don't expect for miracles to happen on NIV. Probably that is what the message. I hope everybody agrees with that, right? Now,
yes, sir.
Coming to the next question, I mean, we had limited number of high flows. limited number of NIVs. How would you choose which patient would get NIV, which patient would get high flow? Mohan sir, Hemant, Bharat, Yash.
Actually speaking, in last 2 months, which we have seen, I have 58 ventilators and 90 HFNO machines in my where we have served here. That is the highest number what I can say, because 2 hospitals, 2 units which we served. So here, as you said rightly, just like indication, if the CT scan score is high, if the respiratory rate is high, start with HFNO for all the patients. Immediately, most of the people, they are not, because really I enjoyed the HFNO, because they are not going for NIV, they are not going for a ventilator, because ABG doesn't matter at that time. Maybe afterwards, it's fine. And you said right, just like intubation or ventilation, if the FIO is going of 80 with the flow of 60, the target is 94 and the respiratory is going high, then go for NIV. This was what we practiced. And as Yash is telling, there is no head-to-head trial, but definitely we will not wait long time with NIV and go ahead and intubate. Even 3 patients, and out of the 2 pregnant patients, we ventilated early and extubated early, and they did well.
Hemant, Mithilesh.
I agree with sir. Actually, I think when the patient is having respiratory distress, respiratory rate around more than 35, requiring more FiO2, is not getting better, using accessory muscle, then it's always better to intubate the patients. And intubating.
How do you choose which patient should be put on HFNC, which patient should be given NIV?
Sir, initially we try with HFNC because in that situation you can give them awake proning little easily. So we see how much amount of oxygen they are requiring, how much FiO2 they are requiring, and depending upon that, if they are not maintaining with that, then we think the respiratory distress is persisting, then we go ahead with NIV.
Bharat, Manish.
I think, Ghanshyam, a lot of things, they are dependent upon what is available at that given point of the time. So, what we used to do, that in case if we find that, HFNC is already being in use for, one of the patient and we don't have, the vacant, this one. So obviously the patient used to fall for an IV. But if I have to, rationalize the indications, yes, if I find that the patient is having a significant respiratory distress and the patient needs a good amount of, the PEEP or EPAP, to support, the patient for whatever the reasons, if the patient is carrying, maybe a morbidly obese patient and all those kind of a thing. So those kind of a patient, they used to fall for an IV. Another thing is that, which I have seen particularly, as Srikanth has said in his presentation as well. See, there is one subset of population who will be really claustrophobic to use of an IV. So the mask is going to be very discomfort for them. One, especially if you're trying to give awake proning, to your patient. With NIV, it is going to be really cumbersome. So be ready that your patient would be requiring some dose of Prisidix or, dexmedetomidine to facilitate that kind of a situation in case if you're using, the orofacial, oronasal mask for NIV. So these were 2 things where we used to have, a lot of troubles. With obviously HFNC, you have an advantage because it's not going to have, that claustrophobia. So, that is going to be a much more patient comfort. But what I have seen in practice, that if your patient is sick, and the patient is heading from mild to moderate, generally HFNC doesn't work because the flow requirements become very enormous. In that situation, NIV is something which is able to meet their, the requirement, which goes difficult with HFNC.
Bharat, Yash, Hemant.
Yeah.
Bharat, no, I have not finished my question. See, in my own patient or in my own ICU, we have never tried both together. We have kind of taken either the HFNC path or the NIV part. And if the patient doesn't get better with either of them, go ahead and intubate. But do you think that shifting or, from using one type of therapy, like HFNC doesn't work, move to NIV and then look at intubation, or if NIV is not working, look at HFNC and then look at your thoughts on that?
Yeah,
Most of us try to do that.
I'll sit in here. See, at times there are patient issues also, like Manish pointed out, claustrophobia or some other issues. So we have to mix and match. Some patients might do good on NIV, some on HFNC. The fixed indications what we had, if work of breathing is too much and distress is not settling down with HFNC, we would have gone for NIV. If CO2 is rising or patient has background COPD, something like that, then we would have gone for NIV to start with. But if it is failing and we see intubation is imminent, we should not just put both together and try to experiment for a longer time. And we should go for timely intubation.
Yeah.
Srikanth, Hemant, your thoughts?
From HFNC to NIV, two things. Someone who is just not maintaining on the high flow and high FiO2 has to go to the NIV, and if the work of breathing is more, has to go on the NIV.
Yeah.
NIV to HFNC, someone who's done well on the NIV, you feel patient is settled, and now you need to make them comfortable. If I have to recommend is not really high, you switch to HFNC. This is what we are.
Very valid point, Bharat. A new thing.
Srikanth, Hemant.
Yeah, so when patient workup breathing, again, as Dr. Yash pointed out, you better off going, when workup breathing is not much, you can go with the HFNC. If patient has a known sleep apnea or you kind of suspect it, you probably can continue HFNC, and in the night when they're sleeping or in the daytime when they're napping, you can put them on CPAP or a BiPAP. Patient has a known severe COPD, use the HFNC, but at the same time, try to use BiPAP or something like that. There is no reason to transition from one to other. So if they're an HFNC, they're not doing well, we are not trying to buy more time by putting them on NIV. That's how we're getting the PSILI effect. And then if they are not doing well on HFNC, I think they need to step down, go to the ICU, and then they need intubation. NIV patients, we decided, okay, we just want NIV because they have a severe COPD, some neuromuscular disorder, or even obesity, hypoventilation, or one of these factors. You started on NIV, they're not doing well, yeah, they go to intubation. Yeah.
Hemant.
Yeah, I entirely agree with most of what Dr. Srikanth has told. Now, just to add, if a patient is worsening on high flow by using NIV, probably in majority of the patients, I feel will be delaying intubation. Maybe in some patients, it'll, if work of breathing is high, and important thing what I see at the bedside is how they're able to talk back to you when you ask a question. If they're able to complete a sentence with ease, I think that means you have some time. If they're unable to complete a sentence, when you ask them a question, I think you shouldn't be delaying. I think, without using NIV as a bridge, I think you should intubate them straight away.
I think a lot also depends upon what kind of a team you have, what kind of nurses you have, what kind of a doctors you have who are going to be there round the clock, people who have the capability of converting or taking the decision of moving from non-invasive to invasive or high flow to invasive. Probably that gives you a lot of comfort.
Someone who's not doing well on NIV has to go for the intubation. But someone who's doing well on HFNC, I would say try NIV, and you can try it for 1 hour, 2 hours, keeping a close watch. But sometimes they really do well. And
exactly. No, I entirely agree with you. But only thing is, you should know when to accept that. Okay, look, NIV is not working, and you should do it. And that decision is crucial.
You need to have a very good team who can make the differentiation. Because if that is happening in the middle of the night, you also need somebody who can take the decision to put them on the ventilator. Yes, Manish.
See, Ghanshyam, there is a slight difference of opinion, what Dr. Bharat has said. See, we have to see why the NIV, in case if you're trying NIV, why the NIV is failing. If the NIV is failing because of, the interface, which is not working in that situation. For example, the patient is getting claustrophobic, and all those kind of a situation, which is actually becomes important. We have seen a lot of patients, they get very uncomfortable with the mask. So in that situation, switching from NIV to high flow nasal cannula has done the justice. But at all the point, So I understand. But at all the points, what I'm trying to say, Ghanshyam, if the patient is having all this kind of strategies, they need to be tried in mild to moderate cases. So if, as I understand what, the Hemant and Bharat, they were trying to say, in any case, if the patient is worsening and reaching to moderately severe category of ARDS, be it any kind of a non-invasive strategy, it has to be changed to the invasive one.
I agree, sir. I think that is the correct idea.
Another topic which we have learned, or another technique of managing hypoxemic respiratory failure that we have learned is awake proning. I'm sure all of you have done it. Your thoughts, Mohan sir, Yash? Because we did a lot of awake proning.
What is the question, Ghanshyam?
Awake proning, your thoughts.
It's a mandatory, sir. There are 5 things, Ghanshyam, when the patient gets admitted, even if it's a day 1 or day 5. What I tell is, please make sure that you have 2 hours of awake proning 4 times a day. And I promote steam inhalation for them compulsory 2 to 3 times, and ask them to take compulsory protein-rich food, and 4 liters of water compulsory if they're not renal failure patients. This is the minimum 4 things which I make sure that, and then ask them to maintain the chart so that by what time, what they did, along with the monitoring of these things. This is what we do, sir. Awake proning is a must for every patient. If I see in the care unit 2 where I was working before, now after joining in Medicover, you will see here, every patient will be on prone position, most of the people.
Manish, you have a smile there.
No, this is how, it happens. When something get good, the people start using them right and left. There was a time before ProServe when everybody used to hate, the proning, and now the proning has become, the standard Bible for all of us, that every patient has to be in a prone position, irrespective of whether we like, dislike the patient choices. So I don't know what to say, but yes, I personally believe that majority of the cases, especially with the mild cases I'm talking about, if you keep them on, the awake proning, especially in the home settings and all, yes, to some extent, they transition from mild to moderate to some. Again, this is not something which, is an evidence-based, but yes, maybe the transition can be halted. But whether it's going to give you any benefit in terms of, the survival benefit, and does it actually going to prevent the transition from mild to moderate to severe, I think it's very questionable. Nobody has been able to say it so far.
Manish, just what you have said a few webinars before, maybe awake proning is evidence in transition. We probably will see the evidence in coming times.
This is what I'm saying.
Hemant,
Yeah, see, those patients, when you prone any patient, oxygenation will improve. I know that's physiology, but the way we have to look at it is when you turn the patient from prone to supine, how fast they desaturate, how fast they decompensate, and that will give us a clue as to whether we should persist with awake proning or we should tube. That's very important. If you go on threatening patient, say you prone, otherwise I'm going to tube you. Okay, he's going to somehow make himself prone, but you'll know that, if you supine him for anything, even for bed care or anything, within 5 minutes, he's going to desaturate. And thus such patients will invariably lose them in the long run.
Just taking that discussion a little further, Hemant, if you intubate this patient, would you not prone him?
Yeah. Okay. Yeah, see, I agree.
Bharat,
No,
if you intubate, would you not prone him? So if the patient is able to put himself in prone.
So that is what Manish was trying to tell you. Proning definitely improves the oxygenation. We all agree to it. So kind of it improves the oxygenation for a while, and maybe a few of them revert back to the normal course. And this is what maybe is saving us. Evidence is not that we might have it. And the same thing, but the physiology doesn't remain the same in the awake proning and in the positive pressure ventilation proning. So there's a difference, and this is why it is difficult to comment. But obviously, oxygenation improves. We have seen it, and it's very obvious on the monitor as well. They just improves, and work of breathing also settles in certain patients, and few turn around. But again, head-to-head trial has to come. I believe it's working, but I'm not sure about it. Yeah.
See, Ghanshyam, can I say something in this part?
Yeah.
I think the concept, I'm not saying that we should not do awake. Yes, we should do awake, proning and repositioning. What I feel that, it has given us the advantage in the form that all those cases which likely to get desaturated faster, earlier in the course of the illness, and they used to receive, the hospital-based attention and all those kind of care. If you prone them, and the chances of, the hospital admission, especially with the kind of, the enormous burden which we were having, I think that was the intention of, introducing, the awake proning and repositioning, so that, some of the things can be buffered right at the outset in the home care based. And obviously in the case where the patient, as, the Hemant has said, where the person is desaturating even for, the slight movements when you're making it from prone to the supine, these are the cases which eventually need to be there in the hospital. So in order to decrease the burden onto the hospital for that given segment, especially in the situation where every 90% cannot be admitted in the hospital, right, in this kind of a pandemic scenario. So if you just prone them in the home settings, and if you're able to have, the SATs of 94-95%, they fall into the mild category and they can be reasonably managed in the home setting. So I think the intention was basically so that you can minimize, as far as, the hospital burden is considered. And as we have learned that majority of the cases, especially with mild to moderate, they're likely to recover by on its own. So you can decrease the likelihood of their, the hospital admission at the same time.
So you would recommend not to prone or try awake prone in a severe patient who's in the hospital?
Awake proning, if you're, no. See, again, I'm saying, Ghanshyam, if your patient is having a significant hypoxemia, And as Hemant has typically described, about the case scenario, this patient, they need to be on controlled ventilation. These are not the cases. Otherwise, tomorrow there will be a recommendation that awake proning should not be done, because we will get more patients because of this.
Just extending the discussion, would you put your patients in awake prone with high flow and or NIV?
For me, if you ask me, yes.
All of you, all the panelists.
No, Ghanshyam, yes, let me tell you that in case if anything is giving you an oxygenation benefit, see, we are talking about at this point of time may not be the morbidity and mortality benefit, but at least the oxygenation benefit, even if you're able to buy the time for them, yes, certainly it has to be done. So in fact, if you're using the proning, apart from using, the NIV agents in the form of high flow versus NIV, I think, yes, it is going to give you a lot of advantage.
So, but prone with NIV, Hemant?
Sorry, I didn't quite get your question, Gacha.
NIV prone.
Why not? Because, when you put patient on NIV, you should have some form of reducing the work of breathing, whether it is high flow or NIV. And if a combination of NIV and awake proning works, so it be. Only as long as we know when to give it up.
Have you tried it?
Yeah, I've tried it.
Bharat?
Yeah, again, the same thing. I mean, we've done it many times. And as we said, it definitely improves oxygenation, and I don't know what happens next.
See, the only problem, Ghanshyam, with the awake proning with the NIV is that, it is very difficult to execute for the patient, because it's going to really interfere with, the mask. So that's why I was saying that in case if you're using NIV, especially NIV with the orofacial mask in a prone position, these are the kind of a subset of population who are not going to tolerate it for a longer period of time. And in case if they're reasonably okay with the single organ dysfunction, in order to improve their tolerability, we have given, some form of a sedation, especially as Srikanth was talking about, the prosthetics has been quite popular for, all this kind of things with us.
Yes, Mithilesh, you were saying something. Raghu, yeah.
With HFNC, the more comfortable and we can manage, but with NIV, there's high possibility of aspiration and
Mithilesh, you were saying something. Agree, Raghu. I'll come back. Yeah. Mithilesh, please unmute yourself.
Yes, sir. We have already tried with HFNC in prone position and NIV also in prone position. NIV patients are not that comfortable, but HFNC they're tolerating. So if they are desaturating in between, we are like giving them that option of being awake prone and with some NIV support and seeing if they're getting better or not.
Srikanth?
Yeah, so in general, awake proning works. It doesn't change the pathophysiology of the disease as such. It helps with the oxygenation. The saturations get better, at least in the time of pandemic when we have struggling with resources. Having proning, awake proning, at least we can limit. It helps understanding why saturation. The concept is there, but in the studies that I've looked at, they haven't changed the outcome by proning alone. It will improve the saturation. Coming to whether they can prone on NIV or high flow, they can absolutely. Again, understanding where to draw the line of awake proning also is known to delay things, and when to draw the line and carefully monitoring the patient. As long as you have a good team support as to look at, they're constantly monitoring them and reporting it to you, that will be good. Any of these strategies to improve the saturation will work.
I think one of the main reasons why awake proning probably is not able to generate the kind of evidence Manish is, with respect to once you intubate the patient and prone, you know that you have a fixed duration. You prone them for say 18 hours, 20 hours, 24 hours. But with awake proning, it becomes extremely difficult to fix a timing because it depends a lot on the patient's comfort levels, the patient's ability. And generally, my observation is females tolerate it much, much better than males. They kind of, they prone themselves much, they're more tolerant to sleeping in prone position than, male positions. Yeah, male.
Bharat helps them.
Bharat?
I agree, but
maybe the body habitus helps them. Yeah. It's just that your tummy out.
Yeah, and we don't put 3 pillows. Srikanth, whatever awake pronings we have done, we have never put pillows. We've just told them to, kind of.
Awake proning, usually you don't need to, because they're awake, they comfort themselves in a way they want.
Exactly. Yeah. I just tell them to get their Netflix or, get any of the series, put it there and sleep as much as you can. Mohan sir, you want to say something? Yeah, I think Mohan Maharaj is busy. Yeah.
You are muted, sir. You have to unmute yourself.
Ghanshyam.
Yeah.
Yeah. Tell me again.
Awake proning with NIV, high flow, duration, and how do you make it more comfortable?
No. Awake proning in NIV is very good because it's all how you motivate the patients. And if you tell them that they're really they're doing very well with NIV, only thing is, as you said, you need to have extra connections, because if you put a proper connections to the sideway, you have a multiple silicon tubes that gives the comfort for them. And proning of HFNO, proning of NIV has been, most of the people, either awake or even people on ventilator in are proning. So we have done a lot and it's really good.
So, gentlemen, it's almost 8 o'clock. If I have to come to some conclusions, I think all of us agree on one part, that do not delay intubations, right? I think universally there has been no kind of a difference of opinion with respect to, if the patient is distressed, needs intubation, severely ill, go ahead and tube him, right? Yes, you can try with high flow NIV in the appropriate patient selection. Awake proning is something that we all can try, probably needs some kind of a sedation, needs a lot of motivation, and needs communication. My personal experience has been that you need to be speaking to the patients to motivate them to do that, or else they kind of completely get lost when you put them on prone position. So something that we need communication, probably better protocols in coming days where we know the minimum amount of duration, probably better sedation policies. Do not pull on with NIV for long. I think again that is something which everybody understands or agrees, that if the patient is not, you feel that the patient is not comfortable or is getting distressed, having a higher respiratory rate on NIV, think of putting them on the ventilator as early as possible. Minimize your oxygen saturation targets. Don't try to achieve 96, 97, 98, 99, 100. Probably this is not a school test where getting 100 out of 100 is going to give you something. 88, 90, 91, 92. In appropriate subset of patients, probably you may achieve a slightly higher target. For example, patients with pregnancies, ongoing ischemia, neurological insults, probably there maybe the targets may be a little different. Dr. Chandrasekhar, any closing comment that you want to have? It was extremely fantastic having you all guys. Dr. Chandrasekhar.
Thank you. Thank you, Dr. Ghanshyam. This is a nice presentation, Dr. Srikanth. This is very educating. You reminded us of our, the physiology class about the, the oxygen dissociation curve, and starting from there to the, took us to these, home oxygen devices, which are very useful for our patient population nowadays. And the, this detailed, discussion by the panelists in the ICU, for the ICU care, and also for the care of the patients in the floors and wards. This is very educating. I hope all of us, all the viewers have enjoyed this presentation. And thank you, the Heartfulness Institute for organizing this event, and AAPI for participating. Dr. Srikanth is a member of the American Association of Physicians of Indian Origin. I'm also a member of that. Dr. Raghunath, Dr. Manish, it's nice to see you as usual. Long, nice comments. Dr. Bharat, Dr. Hemant, Dr. Mohan, and Dr. Mithilesh. Thank you all. And importantly, Dr. Ghanshyam, you're doing an extremely good job. Almost like I was telling him, he's like a TV anchor, conducting the debates. And the next thing you need to do is go into that media.
Okay. I feel the easiest thing to do is ask a question.
No, you are also teaching us, Ghanshyam, and you are a very good moderator, no doubt.
Thank you so much.
Nicely through the course. And this Saturday we are going to have a presentation on stem cell therapy. Dr. Suresh Anne, who is a friend of Dr. Srikanth and myself, we've been all, we're all doing as a team. We've been doing the consultations for Indian patients for the last 1 year without any charges, any cost. And he's going to be presenting on the stem cell therapy. All of you, hope all of you can join. Please come this link will be available for all of you. If you want to come, please let us know. And Dr. Rakesh will provide the link to join this Zoom meeting. So thank you for all joining, and hope to see you soon.
Thank you.
Thank you, guys. Thank you.
Yes, sir.
Thank you,
Thank you,
everyone.
sir.